I have got to tell some jokes. All right. Okay, so we're going to start off to welcome everybody. Thank you for attending. And of course, today we're going to talk about, well, I think it goes into the classification of medications or pharmacology, but we're going to do a little bit more than that. We're going to do a little neurobiology as well and talk a little bit about the brain and then talk a little bit about certain types of problems with the brain, which we all see here, and then why we choose certain types of medications for that. I'm going to try to limit not talking specifically about general medications or specific medications throughout the lecture, but then towards the end we can open it up to questions and we can talk about new medications on the market and things like that. So, but of course I have to start with a joke, which I always do. And this one you guys have probably heard before, but I always tell this joke because I relate to it a little bit, because I don't think I've seen a medical doctor since I went into the Army, which was at, 45 years ago, something like that. Anyway, so there's a guy he hasn't seen a doctor like in 25 years, you know. And his wife keeps telling him, look, you know, you could have some things wrong with you. You need to go in and have things checked out, you know. So finally he reluctantly agrees. And he goes down and he sees the doctor, makes an appointment. He sits down with the doctor. He goes, look, doctor, I got to be honest with you. I haven't seen a doctor in 25 years. And the doctor says, well, I'll tell you what, we're going to give you the best exam I know how to. So he gives him this very comprehensive physical exam. And then he draws a whole bunch of blood work from him. And the doctor sits down with him afterwards and says, look, I gave you the best exam I know how. It was the exam I used to do in medical school. I can't find anything wrong with you. But we did a lot of blood work on you. And I'll need you to come back in 3 days so we can talk about the results of that blood work. So this fellow reluctantly agrees, and 3 days later he comes back and he gets called into the office. He sees the doctor standing in the corner and he doesn't have a very good look on his face. And the doctor looks at him and goes, look, I'm sorry to tell you this, but we got some bad news and we got some very bad news. And the guy's like, oh, well, what's the bad news? And he goes, well, the bad news is we got your laboratory results in and you've only got 24 hours to live. And he goes, well, what could be the very bad news then? He goes, well, the very bad news is I tried to call you yesterday. Okay, kind of funny, right? Okay, we'll do one more, right? So this guy, he's not feeling well. He goes in to see the doctor at urgent care. He tells the doctor, look, I'm just not feeling well. I got a lot of malaise and achiness. And doctor says, well, let me give you an exam. So the doctor gives him an exam, and then he leaves the office and the room, and he comes back a few minutes later, and he's got 3 pill bottles, you know. And he goes, this is what I want you to do. I said, in the morning when you wake up, I want you to take this red pill, and I want you to take it with at least 12 ounces of water. And then around afternoon, around dinner time, I want you to take this red pill, and I want you to take it with 12 ounces of water. And then right before you go to sleep at nighttime, I want you to take this blue pill, this blue-yellow pill, and I want you to take it with at least 12 ounces of water. And the guy says, okay, I'll do that, but you know, what's my diagnosis? And he looks at him and goes, dehydration. Anyway, okay, so let's go ahead and get started, and we're going to talk, once again, we're going to talk a little bit today about medications, pharmacology, and we're going to start off with neurobiology, what I call Neurobiology 101. So I drew some pictures up here, and I apologize for not having slides, but I like to talk and I like to draw. So anyway, and let's keep this as informal as possible. So if I'm moving along, you got a question about something, just holler at me. So I feel like it's more like a conversation between us instead of me lecturing. But these are neurons. And neurons are the way that the brain communicates. And so what happens, and for this, just for the purposes of demonstration today, we're going to call these neurons serotonin neurons. All that simply means is that they store the neurotransmitter serotonin in their tail, or what we sometimes refer to the axon. And if all the neurons in this particular chain have serotonin in them, then that's a serotonergic pathway. And of course, that's just one neurotransmitter. I drew all the neurotransmitters that we have in our body. And so this could be, for demonstrations, could be a dopamine pathway, or it could be a norepinephrine pathway. But just everybody kind of knows about serotonin, so I just chose serotonin for that. So what happens with the brain, the way the brain communicates is by electrical and by chemical activity. All right? And so what happens is, let's say this very first nerve becomes energized. In other words, it becomes electrified. And this electrical impulse kind of travels down this nerve and then around to here. Now, in order for these neurons to communicate, that electrical activity has to get from this neuron to this neuron. And of course, if we know about electricity, it would be nice if the electrical activity could just jump across and that would turn that one on, and then it would jump across and turn that one on. The problem, of course, is that these neurons are surrounded by millions of other neurons that are not serotonergic in nature. And so what would happen is if you had electrical activity jump across this gap, it would also jump across to all these other neurons. And by definition, that's called a seizure. When you have electrical activity that's going in all different directions and not down one pathway, that's a convulsion or a seizure. And so what our brain does, or to remedy that situation, is that these neurotransmitters here, they have little channels. And these little channels in the axon are closed until they become electrified. When they become electrified, the channels open up and the neurotransmitter spills out into this area right in here, this synaptic cleft, or the space between those neurons. Now, if there's a serotonin neuron nearby, it will have serotonin sites, what we call biological binding sites, that are specific for serotonin. So eventually these serotonin molecules find their way over there and they bind at that site. Now, you've all heard this idea, which was started a long, long time ago, with the idea that serotonin, not having enough serotonin in the brain is responsible for depression. That was a simple kind of thought we had a long, long time ago, is that people who are lacking serotonin seem to have depression. So the idea at the time was, well, let's increase serotonin. Now, there's a problem with that. And one is that you can't swallow serotonin because neurotransmitters do not cross the blood-brain barrier. What crosses the blood-brain barrier are amino acids. And then when amino acids cross the blood-brain barrier, they're converted to neurotransmitters, whatever neurotransmitters that the body needs at the specific time. And so if we think that someone is depressed because they don't have enough serotonin, then we would like to increase the serotonin available for binding. And so the way a lot of these medications work, and by the way, in a few minutes we're going to say that we're going to talk about that principle and why it's actually not very accurate. But the way that these neurotransmitters work is they specifically bind at a site that's specific for that particular neurotransmitter. And in most people who are not depressed, for example, we don't really know how much neurotransmitter it takes to turn on that next neuron. But we do believe that we could just pick an arbitrary number. Let's say, for example, it takes 5 of these serotonin molecules to bind, and then that one turns on. And then it takes 5 to bind, and that one turns on. In reality, for a person who's depressed, what it seems to happen is that it may be that they don't just necessarily have enough serotonin, but it might be that for some reason it takes more than 5 molecules to bind. So the concept of loss of sensitivity to neurotransmitters comes into play. And that's probably where most of the research is why that people develop a loss of sensitivity to neurotransmitters. And so the overall goal, if we said simply for this, is we want to help this person with their depression, therefore we want to improve serotonin binding. So we've got to get more serotonin molecules out into this space. Let's say for the person who's depressed, they have to have 10. So what happens here is in a normal circumstances, you get 5 that gets bound, and then once those 5 get bound, then that neuron becomes electrified and turns on. When it turns on, those serotonin molecules are released back into this space right here. Now, you have to get these serotonin molecules back into this neuron so that it can work in the future. The problem is it's no longer electrified, and so there's no way for it to get back in there. And so that's where this concept comes into play. You have these protein transporters, they're called. They're like neuropeptides in the brain. And we have various ones like glycine, aspartate, monoamine, and so forth. But all those neuropeptides, or those protein transporters do, is they gather up this serotonin and they take it back in there. We're not even really sure how they do it, but they have the ability to do that. So these protein transporters are sitting around here, and once this whole process is taking place, they quickly take this serotonin back in there to store it. So a lot of these medicines, and of course Prozac, or fluoxetine hydrochloride, produced by Eli Lilly over 30 years ago, was one of the first serotonin selective reuptake inhibitors. In other words, SSRIs, which are very, very, very popular now. What an SSRI does is they inhibit the reuptake of those molecules. So if you think about it, if we just chose, let's say it takes 1 second for all this to happen. By the way, it's millions of nanoseconds. It's much, much quicker than that. But if it takes 1 second for all this to happen, if you slow down this process of taking that neurotransmitter back in there, you leave the neurotransmitter out here for an extended period of time. And that improves the chances that it's going to bind with that site. So let's say, for example, if it takes 1 second, but this person is resistant, they don't have the sensitivity to the neurotransmitter, these medicines block the reuptake, they slow it down. So now there's 2 seconds available, so you get 10 of them binding instead of 5, and that neuron turns on. So almost all the medications that we're going to talk about today, a lot of them work by blocking this reuptake or slowing it down, basically. It's inhibition. And it doesn't have to be with just serotonin. It can be with norepinephrine. It can be with dopamine. But they basically slow the process down to improve the chances for binding. And that's the biological reasoning behind taking these medicines. And of course, when you think about SSRIs, that's just serotonin, but we also have SRNIs, which basically have the serotonin and the norepinephrine, and we have dopamine, ones that block the reuptake of dopamine and so forth. Most of our medicines work on this reuptake inhibition. Some of our medications also work by actually mimicking that neurotransmitter. That's called an agonistic property. In other words, and we'll talk about that a little bit later on, like when we talk about GABA, which it calms the brain, and you take a Xanax actually makes this neuron think that it's GABA. So it tricks it into believing that it's GABA. And that's an agonistic property. And then we also have some medications that are antagonized that actually block that site. And of course, all these medicines, I've made it really, really simple. It sounds like they're all just very specific for certain neurotransmitter. But in reality, you have about 5 serotonin sites on a neurotransmitter. And a very common one we talk about is called 5-HT1A sites. And then you also have 5-HT2A sites and 3 and so forth. So there's actually more than just one serotonin site. And the interesting thing is a lot of these medicines we'll talk about today will block some of these sites and stimulate some of these sites. This site actually here, 5-HT1A, is the site that's sort of responsible for improving mood. This site right here, it seems like a lot of times this site is involved in people who have psychotic level depressions or melancholic depressions. And so a lot of these medicines, you kind of maybe want to block that site and improve this site. So it's a lot more complicated than what we just talked about. But this is the general gist of how the brain communicates and why these medications have an effect. And I kind of drew this up here for just as a reminder to me because, you know, we've all seen, have you seen people who are like taking Deplin or they're taking a certain type of folic acid? And the reason why they're taking that certain type of folic acid is because you need folic acid to make monoamines. These are a certain type of transport protein in the brain, and it's very, very important for the production of monoamine to have folic acid. But some people have the genetic defect where they can't assimilate regular folic acid. And you can actually identify that now on genetic testing, and we'll talk about genetic testing a little bit later as well. Those people have to have a methylated folic acid, which means that it's a folic acid that has a methyl group on it, and then they can absorb it very well and have more than enough folic acid available to make monoamine. So anyway, actually the whole reason I wrote these little notes up here for myself is to remind me of things so I don't sleep over. This is an important principle, sleep and nutrition. I know you're all aware of that, but it's kind of interesting because we talk a lot about improving neurotransmitter activity in the brain in people who are depressed or have psychiatric problems. And the interesting thing is, remember I said you take amino acids and convert them to neurotransmitters. Like, for example, serotonin comes from the amino acid L-tryptophan, right? And so like if you eat a big turkey dinner that's very high in L-tryptophan crosses the blood-brain barrier. Your brain thinks it needs neurotransmitter serotonin. It converts L-tryptophan to 5-hydroxy-L-tryptophan, which is serotonin. So you need amino acids in order to make neurotransmitters. And so good, well-bounded nutrition that's got protein in it is very, very important, because otherwise you don't have the building blocks to make the neurotransmitters that you need. And this is kind of like an interesting concept, because one of the things that happens with people who are depressed is they stop eating. They lose their appetite. So then they're already showing some either a lack of serotonin in their brain or a lack of sensitivity to serotonin in their brain. And now they've like not eating very well, so they're not getting good amino acids to make the neurotransmitters. And so good nutrition is very, very important, even if the person doesn't feel like eating. And you have to encourage that. The other issue here is sleep. You make neurotransmitters in phase 2 sleep. In other words, your brain, after you fall asleep, which is induction, maybe 30 minutes, 40 minutes after that, you have phase 2 sleep. Phase 2 sleep is the stage of sleep where you make neurotransmitters. And so your brain starts looking around saying, oh, we depleted this, let's make this, let's make that. And it occurs in phase 2 sleep. And then once again, what happens to people who are depressed? They don't sleep very well, right? And so that further antagonizes the problem. Here's an interesting concept as well. When people are struggling with sleep, what's the first thing that providers generally will give them a lot of times? Well, I'm not sleeping, doc. Got to have something to help me sleep. Here, take some Ambien. Here, take Lunesta. Right? And before that, it was benzodiazepines. Here, take Halcion or take Restoril. Right? Benzodiazepines. So we have non-benzodiazepines and we have benzodiazepines that we use for sleep, right? And they work very, very well. But if you go back and look at FDA's approval for Ambien, for example, it says it right there. They approved Ambien for the use at no more than 10 days for sleep. Because what happens is that all sedatives, whether they're benzodiazepines or non-benzodiazepines, if you put an EEG on someone, they won't have phase 2 sleep. In other words, sedatives take away phase 2 sleep, which is where you're supposed to be making neurotransmitters, right? So now you've got someone who's depressed, they're not sleeping, and the doctor says, here, take Restoril for the next 2 months. And they're further, that Restoril's, maybe they look like they're sleeping, but these are the kind of patients, and all the nurses are aware of this. You know, the patient tells you, I'm just not rested, I can't sleep, I'm not know what I'm going to do. But yet all the nurses' notes said the patient slept through the night. Well, the patient doesn't perceive that they had restful sleep because they've lost phase sleep because of the medication. That's why here we're really focused a lot on using alternatives as opposed to sedatives to help people sleep, because we have patients coming to us that have psychiatric problems and depression and so forth, that we don't want them to lose that phase of sleep. By the way, alcohol and things like that also very similarly change your sleep cycle. A lot of people who drink alcohol, they'll fall asleep because they drink themselves to sleep, so to speak, but they'll lose like phase 3 and phase 4 sleep, which is REM sleep and restorative sleep. And so even though they look like they're sleeping, they're not really sleeping. Okay, let's move on. I was just mentioning here, I wanted to mention these other neurotransmitters because we're going to talk about neurotransmitter activity in certain types of psychiatric problems. We do have acetylcholine in our brain. It's responsible for memory. It's also responsible for stimulating our muscles. We have glutamate. And this is very interesting. Glutamate is also responsible for memory. It's also sort of the number one excitatory neurotransmitter in the brain. And the interesting thing is you make glutamate, from GABA, which is the number one neuroinhibitory neurotransmitter in the brain. So GABA calms the brain down, and glutamate excites the brain, and they're sort of made from the same thing. Dopamine, we all heard about, and we'll talk about a little bit more later on, but responsible for reward, is responsible for movement. It's also responsible for our drive to survive. Norepinephrine, or sometimes referred to as noradrenaline, is also activating, and it's also responsible for our flight or fight, responding to things that the body says we need to run away from. And it's also responsible for focus and concentration. And we'll talk about a little bit when we talk about ADHD and those type of things. Serotonin, of course, we all know, mood regulation. Here's an important concept. You have the largest number of neurotransmitters you have in your body are actually in your digestive tract, in your stomach. And serotonin is actually responsible for digestion. And serotonin also plays a role in wound healing, which is kind of interesting. It actually mediates some of the release of the type of your body's defenses that fight off infection and heal wounds. It also has a very interesting thing too, and we'll talk about this a little bit later as well. But serotonin, you know, so far I've said neurotransmitter about 100 times, but these neurotransmitters are also what we call now, they have an ability to regulate other neurotransmitters and other neurons. And for example, serotonin has some play and some involvement in GABA as well. And we'll talk about that like when we talk about generalized anxiety disorder and why antidepressants are helpful for anxiety, even though anxiety is primarily associated with GABA. So anyway, let's move on. Let's talk a little bit about, is there any questions about what we just talked about? I kind of made it as simple as possible because it gets kind of complex when you start talking about all these different sites and stuff. But if we have the general idea, then we can sort of understand why we choose certain medications.
Are there foods that have their neurotransmitters that you can use to make more?
Yeah, you can look in lots of things. Like I said, I mentioned turkey, just happens to be high in L-tryptophan, But balanced proteins usually have a little bit of all neurotransmitters. Balanced proteins, right? So, okay. So let's talk about problems here. Psychosis, bipolar. Is everybody doing all right? Everybody's so quiet. You gotta holler at me. All right, bipolar. Let's see, depression, anxiety, substance use disorder, substance abuse, right? So I'm talking about these certain types of problems, and above them I'm going to write the neurotransmitter that we think is involved in these problems. This one is dopamine, norepi, and serotonin. This is norepi and serotonin. GABA. And substance use disorder involves all of the above, all the neurotransmitters, and we'll talk about that in a little bit. And so what we generally see here So when we generally think about psychosis, by the way, everybody understands what I mean when I say psychosis? Someone who's psychotic has lost touch with reality, they have disorganized thinking, and they may exhibit positive symptoms of psychosis, which means that they have hallucinations and delusional thinking. They can have negative symptoms of psychosis, which means they have depression and social isolation. And really, what I should write up here is schizophrenia, because that's the primary problem. The reason why I write psychosis is because sometimes these other problems here can look like schizophrenia, but it's not the primary problem. But anyway, psychosis is someone who's lost touch with reality, have disorganized thinking, and they have both positive and negative symptoms of psychosis or schizophrenia. And what we really think is that there seems to be an overactivation of dopamine and norepinephrine in the brain. And let's talk about dopamine a little bit too, because I mentioned it earlier. Dopamine is responsible for reward in our brain. We get a pleasurable experience when there's dopamine released in the body. We think that's what ties in a lot to developing habituated type behaviors like gambling, substance abuse, smoking, all those types of things. As a matter of fact, we talk a lot nowadays about process addiction, people who get addicted to video games and things like that. What kind of happens with someone, let's say for example, let's take an example, a young man who's not doing very well at school, perhaps, he doesn't have a lot of friends, but all of a sudden he starts playing some video games, and what he's noticed is he's got a knack for that video game, and he gets the top score. Well, when he gets the top score, he has a release of dopamine in the brain, which makes him feel good, and it also sort of rewards him for that behavior. Now, later on, he starts playing with his friends and stuff like that, and they all start competing and everything else like that. And you heard about these individuals. Sometimes they'll spend 14 hours. They won't even eat, just playing. Well, they're sort of chasing that dopamine reward in the brain. That's how they get habituated. So dopamine is a very powerful neurotransmitter. And we'll talk about that later on when we talk about like opioid abuse and so forth. But dopamine is responsible for reward. But you have a number of pathways in the brain, dopamine pathways in the brain. You have another pathway that's responsible for movement. So dopamine is also responsible for motor movement of our body. Can anybody think of a problem where you don't have enough dopamine in the brain and then you have trouble moving? Parkinson's disease. And so what's really interesting is you take someone who's Parkinson's disease and it's hard for them they have that shuffling gait, it's hard for them to move. And you can give them L-Dopa, which is a precursor to dopamine, and improve their dopamine, or you could also give them some of these newer medicines which are dopamine agonists. In other words, they mimic dopamine in the brain. And you'll improve their movement. But guess what? If you give them a little bit too much, you have a little old lady with psychosis because you gave them too much dopamine, right? And here's another thing too. If you give someone who's psychotic a D2 blocker, in other words, a dopamine site blocking agent, like an antipsychotic like Zyprexa, if you give them too much, they will get pseudo-Parkinsonism, where they have trouble moving, right? And you have to actually give them medicine to reverse that or lower their dose of that dopamine blocking agent. So dopamine is a very important neurotransmitter, responsible for reward. It's also responsible for motor movement, and dopamine is also very, very, very important in, there's one specific pathway in our brain associated with dopamine that is responsible for our drive to survive, our instinct to stay alive. And that's going to become very important when we talk about substance use disorders. But you may have noticed here that I drew these sort of in order. And the reason why I did that is because one of the take-home points today is that how efficacious or how effective a medicine is depends a lot on how much of that problem is organic or brain-based, right? And that's why I drew it like this. Although there are exceptions, we'll talk about that in a little bit. But in general, schizophrenia, how much schizophrenia do you think is related to brain? A lot. Yeah, that's a good answer. Yeah, probably 100%. It's a brain disorder. You're born with schizophrenia. And the interesting thing is there were some studies that were done a long, long time ago, like 40 years ago or longer stuff. They actually came out and said that you could create schizophrenia. You had a certain type of mom, a schizophrenic mother, the way she mothered her child would create schizophrenia. Of course, it was laughable. The study was actually published, but it was a laughable study. But we know schizophrenia is brain-based and that you're born with this defect. We don't exactly know the defect, but it has something to do with too much dopamine and norepinephrine in the brain. Maybe you're too sensitive to dopamine and norepinephrine in the brain. But this is a brain disorder, and it usually manifests itself between ages maybe 17 to 25, something like that. And here's an interesting thing. You'll see as we go along here today, I'm not a person that says, oh, you always got to take medicine, you got to take medicine, right? But if you have schizophrenia, you absolutely have to take medicine. You cannot get well. As a matter of fact, there were some studies done, several repeated studies that showed something very interesting. If you take someone who has their first psychotic break, they lose touch of reality, and it's the first episode, right? And you put them on an antipsychotic agent, right? In about 2 weeks, you can get them back to about 98% of their functioning. In other words, they'll look exactly like they did before they had that psychotic break. It's quite amazing. And it happens very quickly. Now, but let's say, for example, this person who has schizophrenia stops taking their medicine and they have a second